Would you just say again the RFP process you were describing, is that a process to move the $60 million into the demonstration projects, or was that related to program evaluation? I didn't follow all of the connection.
It's each of those. And so one contract we're going to be, actually an RFP or solicitation we'll be putting out, is to engage one statewide evaluator from the beginning. So from beginning to end, we have that piece. Then we're going to provide for each of those respective 5 groups technical assistance providers, as well as capacity building projects. So capacity building is for those communities or community-based organizations that have historically been shut out. And they're providing a great service, but administratively, operationally, they may not have the capacity just now. So we'll be issuing capacity building pilot project contracts. And then for those that are more established and ready, the traditional demonstration and or implementation pilot projects. And I'll make sure we provide the summary to you that outlines each of those 16 solicitations. But when we execute on the different grants and contracts, it's anywhere between 50 to 60 different contracts and grants that we'll be monitoring on an annual basis.
And can school districts apply or other bodies of education apply to do school-based mental health? And if this isn't the right pot of money for that, then advise me on where. But I can tell you for a fact a number of members in the legislature, including our office, is interested in launching some pilots on school-based mental health delivery to help students who've been impacted by trauma, or just to fill the need that exists because there are not mental health providers in school very much anymore. Yes. So I'm just putting it out there. We like to figure out a way to support as many districts as possible to be able to provide this service. Is that something that would work through this RFP process, or would those school districts need to work through a different funding stream?
They would very much so be eligible. And what we've encouraged on the local level is collaboration. So if you have your local mental health department, a community-based organization, and, for instance, a school district, it's a great collaborative opportunity for those entities to come together that have a unique interest, say, for instance, in our children. And then there are other, from a gender perspective, sexual orientation, there are many opportunities for the traditional and the non-traditional groups to come together and seek funding opportunities to invest in that. So yes, schools would be eligible.
Can we speak further beyond today's hearing? I know of at least 2 bills that address school-based mental health, and if there's a way to link the delivery of the service to that funding, if that's an available funding stream to move the services, we'd like to talk with you further, yes, just to understand how that might work. Thank you. Is there any public comment on this issue? We welcome public comment on this issue, and if you had intended to give public comment on the budget change proposal for the medical disaster preparedness in the last segment, we'll give you that opportunity to do that now too. 1 minute each speaker. Welcome.
Kimberly Chen with the California Pan-Ethnic Health Network. I want to thank Director Miller for his comments, and we've been very supportive of the Office of Health Equity and look forward to putting out that strategic plan for the CDRP project. We're also very much looking forward to the statewide strategic plan and the demographic analysis that it will provide for our communities facing health equity challenges. Thank you.
Thank you. Any other public comment? Seeing none, we want to thank our panelists, and we'll move on to the next issue and look forward to continued conversation. Our next panel is on the Center for Environmental Health Issues. We'd like to welcome Mark Starr from the Center for Environmental Health, Miriam Klein, also from the Center. We'll have staff available from Finance and the LEO's office to address any of the items presented. Mr. Starr, whenever you are ready, we are ready.
I'm ready. Thank you, Mr. Chair, members. A member at the present. I'm Mark Starr, Deputy Director for Environmental Health in the California Department of Public Health, and I have with me Marin Klein, as you've noted, our Assistant Deputy Director. Thank you for the opportunity to address Issue 2 in your agenda, to provide an overview of our Center's 5 budget proposals. I'll first provide a very brief, high-level description of the Center for Environmental Health for a little context, and then provide a brief overview of each proposal. The programs and expert staff in our center work to protect and improve the health of all Californians by ensuring the safety of food, drugs, and medical devices, by conducting environmental management programs, including medical waste, which you'll hear a little bit more about in a moment, and by overseeing the use of radiation. These are our core program areas. We do this through investigation, inspection, laboratory testing, regulatory activities, and emergency response. The programs with proposals before you today include the Food and Drug Branch, the Environmental Management Branch, and our Drinking Water and Radiation Laboratory. I'll begin with the Food and Drug Branch, which has 3 of the 5 budget requests, and then I'll go on to the other 2. I also would like to compliment your staff for the excellent write-ups in your agenda package, which will allow my comments to be brief. Welcome to everyone, I'm sure, to hear that. So the first request is titled Food Safety Inspection. Our Food and Drug Branch's role includes conducting statutorily mandated inspections of food processors, as well as distributors, in order to ensure food safety and to reduce the incidence of food contamination and ultimately foodborne illness. This request is for 6 permanent positions and $804,000 authority from the Food Safety Fund in order to meet these responsibilities. This is essentially a workload-based request, increasing our field staff from the current 17 to the needed 23 positions, and no increases in fees are being requested. In short, business is good in California. There's a number of new food facilities that are looking to be registered with us. It has increased over 60% over the last 5 years, the number of new applications. And we also have an increasing inventory of existing food facilities, processors, and distributors over the last 5 years. However, staffing levels have not kept pace with the new workload generated by these increases. So the impact of these 6 new positions will be significant. Our Food and Drug Branch will be able to meet statutory mandates, ensure new businesses are registered and become operational as expeditiously as possible, and will be able to continue the high level of protection of food supply and help reduce the incidence of foodborne illnesses in California. If you'd like, I can go on to the second one and get to questions at the end. Is that your preference? Perfect. Our second one is also in the Food and Drug Branch. It's also food safety. It's called Food Safety Stipulated Judgment Agreement, and there's also a trade or bill language along with this proposal. Our Food and Drug Branch's role in food safety that I just described also includes the authority to address the safe storage and transportation of foods, including appropriate sanitary conditions, temperature controls to prevent the growth of microorganisms, and other aspects of transportation and storage. These things are currently evaluated at the location of processors and distributors during facility inspections and in response to complaints. As in your staff write-up in July 2013, in response to a complaint from a news organization who had been alerted by an informant, our Food and Drug Branch investigated Cisco Corporation and found extensive improper transportation and off-site storage violations. This led to a civil complaint and a stipulated court judgment, $3.3 million of which is dedicated to the Department of Public Health for the purposes of conducting field-based food safety, transportation, and enforcement activities. These funds provide an opportunity to better address this area of food safety than we have been able to in the past, and does so without increasing fees. So this request is for 4 5-year limited term positions and authority to use $716,000 of these settlement funds in the first year and continuing over 5 years in order to implement the food safety, transportation, and enforcement activities resulting from this court judgment. Our department is also requesting approval of the accompanying trailer bill language to amend the Health and Safety Code that will allow us to deposit funds such as these into our Food Safety Fund. This proposal will provide the necessary resources for our Food and Drug Branch to further investigate distribution practices and to ensure the companies are protecting food throughout the distribution chain. Our third request, also from our Food and Drug Branch, but not food related, is the tobacco retail inspection contract. This proposal is for 9 limited term positions and roughly $1 million in additional reimbursement authority for the remainder of our department's contract with the United States Food and Drug Administration. This is for the Stop Tobacco Access to Kids Enforcement Unit, or STAKE, in order to inspect tobacco retailers in California. Our Food and Drug Branch's role in the STAKE program has existed since 1995, focusing on retailer enforcement and to reduce illegal tobacco sales to minors. Since 2009, as a result of a federal law change, the Federal Food and Drug Administration was required to contract with states to conduct youth tobacco enforcement activities. The new 3-year contract is effective October 2014 between FDA and our department. Funds expanded activities that will accomplish retailer compliance checks of 20% of California's 37,000 licensed tobacco retailers each year. So the requested 9 positions and reimbursement authority will allow CDPH to fulfill the contract expectations from the Food and Drug Administration. In addition to increasing compliance, our enhanced presence in retail establishments will increase awareness regarding tobacco use by minors. And importantly, I should mention that stake activities reduce the illegal tobacco sales rate to minors within California. That's our goal. It makes young people less likely to become addicted to tobacco and nicotine, and reduces the associated chronic illnesses and decreases mortality and decreases healthcare costs. Our fourth request is titled the Medical Waste Program, and it's based on AB 333. This request is for 3 2-year limited term positions and $330,000 annually for 2 years from the Medical Waste Management Fund. This will implement the mandated provisions specified in AB 333 that was chaptered last year. This bill provided updates to the Medical Waste Management Act and ensuring public health protection for the proper transportation, storage, and disposal of medical waste. This is the first major update of this act in 23 years. So in order to protect the public and workers from inadvertent exposure to pathogens and medical waste, our department's Medical Waste Management Program enforces the Medical Waste Management Act. This is accomplished through oversight of all aspects of medical waste, beginning with the generation of the waste all the way through transportation, storage, and disposal of medical waste. Because federal law via the Department of Transportation also governs the transport of medical waste on public roads, AB 333 requires our department to convene stakeholder meetings and submit a report to the legislature describing the interaction of federal and state law for the transport of regulated medical waste no later than this coming January. Because DOT allows a party to petition for preemption determination, there's also provision in the bill when there's a conflict between state and federal law for us to temporarily waive the bill's requirements. And the bill authorizes us to update standards related to the transportation of medical waste through the issuance of guidance documents. So these requested positions and expenditure authority will allow CDPH to perform the workload associated with AB 33 implementation over the next 2 years. These activities will assist the healthcare and medical waste industries with compliance and further protect workers and the public. And our fifth and final request is titled Public Beaches Inspection for Contaminants. This is also driven by legislation. It's for 1 3-year limited term position, a microbiologist, and $384,000 of general fund in 2015 and 16, and then a decreasing amount thereafter for the 3 years. This will allow us to implement the mandated provisions of SB 1395, also chaptered last year. That bill authorized the department to allow local health officers to use a CDPH-approved rapid testing method as a single test for contamination of beach water under certain conditions. And the bill authorizes our department to develop testing methodology and guidance for alternative beach water quality testing and to validate site-specific uses of that testing method. Just as a quick summary of the roles for beach water quality testing, local health departments are responsible for the sampling and testing of the water, posting or closing beaches when necessary to protect the public, and then reopening the beaches when testing allows. The current permissible tests are culture-based and tests for 3 different indicators. Our state laboratory, the Drinking Water and Radiation Lab, effort in this area is to develop and evaluate test methods to assure water quality. So this is a new rapid test method that was released as a research method by the Federal Environmental Protection Agency, and it's called quantitative PCR. And the idea is to allow rapid testing in a matter of hours rather than the current 2 days. I won't get into the details of this type of test other than to say it's highly complex. It involves looking for the DNA of the organism, in this case Enterococcus. It's susceptible to cross-contamination, interference from other substances. So because of that, EPA left it to the states to develop guidelines and criteria for implementing qPCR. So that will be our role as a lab. There's no currently approved methods for the use of this at saltwater beaches. It's a technology that's rapidly evolving in an area that our laboratory will need to establish all the standards and guidelines for in order for local health departments to use it. is not yet a reliable and well-established practice like conventional culture-based methods, and there are no California laboratories currently certified to conduct this testing. So this essential work by our state laboratory will enable local health departments to consider use of new and complex rapid testing methods for beach water. It's an alternative that's expected to result in more timely determinations of public health risks and shorten durations of beach closures. Thank you for your time. Any questions?
Thank you, Mr. Starr. Ms. Klein, anything to add?
No,
Any,
not at this time.
thank you. Anything from finance? Anything from the LEO's office? Questions from the committee? We have 5 budget change proposals here as proposed. The recommendation is that we approve all 5 budget change proposals as proposed and also approve the proposed food safety technical placeholder trailer bill. Can I have a motion to that? Motion, could we have the roll, please? I'm sorry, do we have any public comment? Any public comment on this item? Moving on. Can we have the roll, please?
Thurmond,
Yes.
Bonta, Chu, Grove, Jones.
Motion passes with 4. Any questions for our panelists? Thank you very much for your presentation and your great work. Thank you. Moving on to issue number 3, the Center for Family Health Issues. Connie Mitchell, Dr. Connie Mitchell from the Department of Public Health. Laurel Sema, also from the Center for Family Health. Kristen Rogers from the California Home Visiting Program at the Center for Family Health. We'll have representatives from Finance and the LEO's office as well. Whenever you're ready to begin.
Okay.
Thank you.
Good afternoon. I'm Connie Mitchell, the Deputy Director of the Center for Family Health. In our Center for Family Health, we have 3 divisions. We have the Women, Infant, and Children Nutritional Program, commonly known as WIC. We also have genetic disease screening, and we have maternal, child, and adolescent health. On the agenda today are 2 programs that are within our maternal, child, and adolescent health division. We have a follow-up on progress made with our Black Infant Health Program. And then we are also going to talk about, we have a BCP from our home visiting program. So those are the 2 items on the agenda. I have with me here the branch chief, Laurel Sema, oversees the Black Infant Health Program in case there's more detailed questions that I can't answer. I'll just go with a kind of a brief overview of where we're at. The Black Infant Health Program actually started in 1989. There was already awareness. You heard from Mr. Miller, the Deputy Director, about our efforts to address health disparities, but in the late 1980s, our surveillance data was already saying that we were experiencing disparities, particularly between Black or African American mothers and children and the white population. And so there was an effort that began early on to try to understand that population and their needs and to see if there was any particular programmatic efforts. At the time, the issue was around access to prenatal care. So that was the majority focus, was on accessing prenatal care, getting women in early into prenatal care. And so then we watched the data over time, and while we were successful in getting women early into prenatal care, we weren't really moving the dial that much around changing the outcomes for either mothers or children. We were lucky in that our first pilot efforts, we were fortunate to get some state general funds for that effort. The combination of Title V funding, state general funds, and matching Title 19 funds. At one time, we had a budget of around $8 million for the state program. Then in 2009, all state general fund was eliminated for the program. That meant that Title 19 drawdown could no longer occur. We were left with a very small amount of Title V funds. During that down period of time, 2009, 10, 11, what we did was, since we realized that despite our good efforts to get women into prenatal care, that we weren't really changing our outcomes, we hired a consultant, Dr. Paula Braveman from University of California, San Francisco, and her Center for Health Disparities. as a contractor to help us to understand, what were we missing, what more could be done. And based on the evidence that she provided to us, it looked like there was a model called a centering pregnancy model, where bringing women together in groups seemed to have a very empowering effect on women, created a strong social support network. They could exchange information and ideas. We also learned that African American women may be suffering a lot more in terms of chronic stress, weathering from chronic racism. So we wanted to try to directly address that. And so we took the best evidence that was out there around addressing disparities, completely revamped the Black infant health model, and began to implement it in 2012, although we had very little funding to do it. We wanted to at least make an effort to get it started. What we found out is that since we were now it was more than just getting people referred into prenatal services. It was about bringing women together on a regular basis, helping them to make changes in their life where they felt more in control of whether it's their finances or the chronic stressors that they faced. The commitment was for 10 weeks in the prepartum phase and 10 weeks in the postpartum. So that was a big difference. That was a 20-week commitment.